welcome to Invest Digital Health. My name is Orundhati Parmar, and I'm the editor-in-chief of MedCity News. I believe we are now slowly beginning to thoughtfully address social determinants and population health. Before it seemed to be a lot of lip service, but given what we encountered during the pandemic, where people of color disproportionately were hurt and died, I think now the healthcare industry as a whole has woken up to the fact that social determinants and population health go hand in hand. And I'm pleased to introduce our panel, some of whom have long thought of these issues even before the pandemic. So we have Kimberly Ibarra. She'll be our moderator today. Lucille Aceta, Allison Hess, Andrew Renda, and Trenner Williams. In her current role, Kim leads the design and execution of innovative approaches to address national healthcare priorities, including the social determinants of health and health equity. Kim has a broad range of professional experience across the healthcare sector in the US and Canada, working in home and community-based service organizations, palliative care, international HIV/AIDS advocacy, hospitals, and academic research. Kim holds a Master of Science in Health Services Research from University of Toronto and an Executive MBA from the Kellogg School of Management and Schulich School of Business. Again, she's the Senior Managing Director at National Quality Forum. Welcome to you, Kim. Lucille Aceta is Senior Vice President of Product at CVS Health. In this role, she leads development of all specialty pharmacy benefit clinical drug affordability, care management, and formulary products and services for clients. She joined CVS Health in July 2017 as Vice President, Specialty Programs Management, in which role she was responsible for specialty therapy strategy, benefits verification, as well as the pharmaceutical manufacturer reporting and pharma account management teams. She has a bachelor's degree in pharmacy from St. John's University College of Pharmacy, New York, an MBA from the Fordham University, and a master's in health policy and management from New York Medical College. Welcome to you, Lucille. Andrew Renda is Vice President of Bold Goal and Population Health Strategy of Humana. He leads Humana's mission to help improve the health of communities it serves by making it easier for people to achieve their best health. His work includes leading 4 population health and social determinants of health work streams, insights, strategy and execution, informatics, and thought leadership. He's a published author and speaker in the fields of population health, social determinants of health and chronic disease. Andrew has a BS in psychology and biology from the University of Kentucky, where he was a National Science Foundation undergraduate fellow. He received his medical degree and a diploma in clinical psychiatry from the Royal College of Surgeons in Ireland, followed by a master's in public health from Harvard Chan School of Public Health. Welcome to you, Andrew, and it's nice to see you again. I know we had you back in 2016 to talk about these issues, and it's a different world right now. So glad to have you on again. Allison Hess, she is the Vice President of Health Innovations at Geisinger. She's been part of the Geisinger family for 14 years and is responsible for the oversight and implementation of health and wellness programs for Geisinger patients and insured members, employees, and community members. She started her career in community health education, corporate wellness, and has continued to expand to include innovative community-based population health initiatives driven by data analysis and clinical outcome measurements. Allison has earned a Bachelor of Science in Health Education and her MBA from Bloomsburg University. She has been the recipient of several awards focused in various areas of health, including health equity, worksite wellness, and supply chain. She has also been recognized nationally for her work with the Fresh Food Pharmacy Program. Welcome to you, Allison. And Trenner Williams is co-founder and CEO of Socially Determined. Trenner is a family physician, entrepreneur, former health system executive and consulting leader, and the founder and CEO of Clinovations, which he sold to the advisory board company in 2014. In 2017, Trenner co-founded Socially Determined in order to create an analytics platform that integrates the social determinants of health with clinical and claims data in order to quantify and visualize social risks and the specific impacts on health and healthcare outcomes. Socially Determined creates holistic models of people, the communities they live in, and their interactions with the healthcare system. With more than 20 years of healthcare experience, Trenner's unique perspective is formed at the intersection of healthcare and technology. Welcome to you, Trenner. I just wanted to mention that before I handed it over to Kim to ably steer this conversation along, we welcome questions from the audience through the chat. So as discussions come up, if there's a question that any member of the audience has, please feel free to put it in the chat and Kim will weave it in. So over to you, Kim.
Thanks, Arundhati, and thanks everyone for joining us today. For those who may be unfamiliar with National Quality Forum, we're a nonpartisan, nonprofit, membership-based organization in Washington, D.C., and our members represent more than 350 organizations from every sector of health and healthcare throughout the U.S. Our mission is to be the nation's trusted voice driving measurable health improvements. And while we're most well known for our work in quality measurement, we have a body of work over the last decade on addressing the social determinants of health, or SDOH for short, and health equity. And so I'm really thrilled to be moderating this panel with our speakers from across the US who are experts in this area. I wanted to start off the panel by asking each of you about your efforts underway in social determinants of health. As leaders in this space, can each of you share with us more about what you or your organizations are doing to tackle the social determinants? Trenner, why don't we start with you?
Thanks so much, Kim. And thanks to MedCity as well for giving us the opportunity to have this important conversation today for sure. So I am the CEO and one of the co-founders of Socially Determined. We've created an analytic platform with the ability to characterize and measure social risk. And so we do that by thinking both at the community level, the risk that somebody is exposed to, whether that's around food insecurity or financial strain or the lack of effective transportation or housing and stability, and do it at the person level as well. So we understand an individual's personal risk as it relates to their healthcare journey as well. It's been really important for us as we partner with health systems, health insurance companies, life science companies, government agencies. As Arundhati said before, the world has changed over the last 5 years, and we have the opportunity to help quantify and measure social risk, the impact that it has on organizations' business and the metrics that matter to them. So the variation that social risk causes in clinical, financial, and experiential outcomes, help organizations prioritize what actually to do with that information so that they can have an impact on people, populations, and communities, and importantly, measure that impact so that organizations can sustain programs that work, scale the ones that can be scaled, and sunset or tweak ones that need to be tweaked. So again, it's great to be here. Thanks for the opportunity.
Thanks so much, Trenner. Andrew, over to you next.
I just want to, well, thank you first, but I want to borrow Trenner's answer because I feel like that's a lot of what my organization does as well. So I'm Andrew Renda. I work at Humana. I lead population health and the Bold Goal strategy. For those that you don't know, Humana is a health and well-being company that has insurance products across a number of lines of business. We also have payer agnostic services for primary care and for home health. So that's grounding. And Humana has a bold goal, which is to improve the health of people and communities we serve by making it easier for people to achieve their best health. Now, what that really means is that we want to improve whole person health, which includes physical health, mental health, and social health. And the work that I lead is the social health side of that. So we have a corporate strategy where we go, direct to consumer, direct to patient with social determinant type interventions and things like that. We also have a localized strategy where we have a footprint of what we call bold goal communities across the country. We have 16 geographic communities and a virtual community for veterans, where we really have a localized approach of trying to address the specific social needs and chronic conditions that exist in that specific area. So just, to sort of tee up this conversation today, I think, often the question is, why social determinants? Why address them? And I think the sort of simplest answer for me, because we've surveyed a number of our members, is that they exist, that they're highly prevalent and they impact health and health outcomes. So just a couple of quick stats. We surveyed 100,000 of our Medicare Advantage members. We found that 40% of them have a financial strain. 30% of them are lonely. 26% are food insecure. And so they're highly prevalent things. And then when we look at them, they are having a dramatic impact on the stability or lack of chronic conditions and the progression of disease and all the utilization and costs and things that go along with it. So that's the call to action. That's why we're doing this work. And I think we'll get into more of sort of the technology side and the data and the analytics and all these things that I want to talk about. But maybe I'll stop there for now, and I'll pass on to the next speaker.
Great. Thanks, Andrew. And I know we talked earlier about how we wish the session could go 3 hours so we could really talk about everything that everyone's working on in their programs. But Allison, why don't we go over to you next to talk a little bit about your work at Geisinger?
Yeah, absolutely. And thank you again for having me today. Geisinger is an integrated delivery system. So we have obviously a provider arm, and we also have the payer component. We have a school of medicine as well. So a large integrated delivery system in Northeastern PA. And really what we've been focused on the clinical enterprise end, as well as from the payer side, is really how do we get care closer to home? How do we get care to the communities where people live and work, and decanting some of that care from the hospital and the primary care office, especially around the social determinants of health space, but still remaining connected, because we think that connection to healthcare is really important. We've done that through a variety of different ways. And we've really been working on organizing our efforts around social determinants of health, leveraging existing and new technology. And we've come up with 4 pillars in our strategy. The first is really around the data and the collection of information, creating that universal screening, so that we can leverage not only our own data, but also state available data or other data that we have access to really create that longitudinal record for our patients, for our community members, to provide them the best level of care. The second piece is that connection point to the CBOs, and making sure that we are being connected with the community-based organizations, that they are at the table and driving the work, that they're making the decisions. In fact, when we selected a social determinants of health platform, we actually had the community-based organizations make the final decision on that platform. So really engaging the communities in a very different way, so that they're not only, they don't have a seat just at the table, but they're actually driving the decisions in this space right alongside of us. We also think the third piece that's really critical to our strategy are the programs that we're doing and connecting that healthcare and social care component. And then the last piece, which I think others touched on as well, is that we can't lose sight of making sure that we have those measurable and sustainable outcomes, so that we can promote sustainability in this space. And I think, the funding streams and all of those things, from my perspective, wrap into that sustainability. And that's an important component of where our focus is.
Thanks, Allison. And last but not least, Lucille, over to you.
Thanks, Kim. Really great to be here, and alongside these great panelists with Trenner and Andrew and Allison. CVS Health has been really active in the community, helping to address disparities through projects like Project Health, and which offers free biometric screenings in underserved communities across the country. We also just recently launched an expansion of our efforts to help decrease these health disparities among patients in really 3 areas: sickle cell disease, HIV, and cardiovascular. And like Allison, we've kind of executed in 4 pillars, but in a different way, addressing the awareness and education, increasing testing and screening, and increasing access to health services, and also looking at treatment optimizations and intervention. So that's really where CVS's focus has been. And we have some goals that we want to achieve, and that's to decrease the opportunity for individuals that can have sort of support and help across their needs. For example, doubling the number of patients on hydroxyurea for people living with sickle cell, increasing awareness about HIV testing and prevention for our members, and particularly among communities of color, and sharing educational resources out there for those who are at risk. So really, we're very focused on making sure we're reaching populations and leveraging, and we'll talk a little bit more, as Trenner mentioned and Andrew, around the data and the populations where we're collaborating in the community organizations, and what's really important with these patient advocacy groups as well, to message and intervene and deliver the care where people are at their point in time.
Thanks, Lucille. And what I really love about this panel is just how everyone is tackling social determinants of health, but in different ways and through different avenues. You're all leading successful SDOH programs and efforts that are nationally recognized. Wondering if you can share with our audience what have been the top 1 or 2 success factors that have really been critical to the success of your programs. Andrew, why don't we start with you this time?
Yeah, thanks, Kim. I mean, I think there's so many different success factors, but I think it's really important to first really ground in terminology, and names and terms and codes and things like that, and then the data ecosystem that surrounds our ability to measure impact of the things that we're doing. So just as an example for that, I think people sometimes use social determinants as almost a generic term. Whereas really there are sort of different levels of when we talk about social health and things that we're doing. So for example, there are structural determinants of health, which are really kind of the social and political context that people live in. Then there are social determinants of health. Those are upstream influencers of poor health. And then there are health-related social needs, which are more individual and immediate needs like food insecurity and things like that individuals need help with today. So I think sort of putting that architecture in place helps ground us in the terms and things that we're actually talking about. Then it becomes really critical to make sure that when we're assessing for needs like that we're using validated screening instruments. So we use the Accountable Health Communities comprehensive screener. We use the USDA Hunger Vital Signs screener for food insecurity, the UCLA Loneliness Scale for loneliness, and so forth, and so on. And then once you're doing that, you're using validated terms and you're standardizing data, bringing it into an ecosystem where it's sort of certified and standardized so that you can use it for platforms, reporting, advanced analytics, predictive models, all that kind of stuff that you want to build off on this foundational architecture. And that enables you to measure, because I think what it really boils down to is measuring everything. On the front end, you look at populations, you get insights on what needs exist and where and how to target people for specific needs and interventions. On the backside, you want to measure the impact of what those interventions have. So did they improve health-related quality of life? Did they close the social need gap? Did they improve utilization and cost and so forth and so on? And I think that also helps articulate the value proposition ultimately behind all of this work that we're doing around social determinants or social needs, because I think the value proposition certainly can be an ROI in a specific intervention, but it also, it may help with, in our case, growth and retention of membership, or may help us win new business if we see things about population health and social determinants in RFPs for state Medicaid contracts or group Medicare contracts or things like that. So, it also sort of behooves us to kind of think about value proposition in a broader sense than just pure ROI on a specific intervention. So I'll stop there. There's a lot to say, but I think, the bottom line is it's underlying data and terminology, I think, that we have to ground ourselves in before we can even start to look at other success factors.
Thanks, Andrew. Lucille, how about from your perspective?
Sure. We sort of went in a unique perspective. We built and continued to evolve. I would call this robust data layer, where we incorporated several hundred data points from various public sources, but also our own internal data around prescription claims data. And we looked to see how we could help our clients better identify not just what disparities there were, but also where these members are impacted, where they live. And we found, and just for an example, our data analysis showed that disadvantaged populations in certain predominantly minority communities are greatly impacted, let's just say from one of the conditions we looked at, cardiovascular disease. And what we found were a couple of things. One, they are either not initiating treatment, or when they are on treatment, they're not at an optimized dosage. So we really took the lens of how can we care for members, and not only through our processes, but also impacted that information through our programs and capabilities. So Kim, that's how we kind of took that component of the strengths of the data.
Thanks, Lucille. And Trenner, I know you work with various organizations like health plans, providers, government, nonprofits, life sciences organizations. In your work with them, what would you say has been most successful, or what factors have been most successful for them in working on SDOH?
Yeah, Kim, like Andrew said, there are a lot, but I'll call out two that I think are really important. One is visibility. And we in a very simple way, we use this picture of Fenway Park where there's people that buy seats behind a stanchion and have a limited view of what's happening on the field. We think healthcare is a lot like that. We have a limited view of what's actually happening in people's lives, and we certainly have the opportunity to use the robust clinical and claims data that we have access to, but that doesn't clearly tell the full story. So what we found to be a really successful tactic is to create visibility or understanding of what's going on specifically in people's lives. Michael Melanson asked a question in the chat about how do we use some of the robust personal data that's available. So we think about being able to leverage in a secure, private way when we're under a BAA, but take the opportunity to be able to use aggregate and individual data to construct risk scores and risk metrics and other information about a person rolled up to about populations and about the community in which they live. That visibility, providing that view, one common view that everybody can look at, you start to better understand, again, what risk people have, and to Andrew's point, how that translates into social needs. What we have found too, that idea of combining that intelligence, that social risk intelligence and that visibility with the thoughtful screening, that whether that's at Humana or Geisinger or at Caremark as part of that, is a helpful front-end tool to better know who's at risk. The second tool, or the second maybe aspect of success, is intention. And I think where we've seen organizations, it's not enough just to understand what the need is and say, we see food insecurity, so we're going to open up, whether, again, the unbelievable Geisinger fresh food pharmacy that exists or other tools around that. Understanding who has addressable risk. So with intention, deciding who we're going to proactively reach out to, who do we engage, what's the messaging around that, and how do you start to enroll and pull people into those programs with intention. And I think if we want to see real measurable return, those two, getting visibility of the full playing field, and then with intention acting upon that.
Thanks, Trenner. And Allison, what have been one of the top one or two critical success factors for you? And I'm also wondering if, Allison, you can talk a little bit about the fresh food pharmacy. There is a question in the chat related to food insecurity, and I think you have such an innovative program there that might help address this question.
Yeah, absolutely. So I'll address the first question as far as kind of the key measures. And I think, as many have noted, data is just incredibly critical, right? So even when we did our fresh food pharmacy program, we started with what we wanted to measure, what outcomes we wanted to track. We really thoughtfully recognized that we needed to make sure that we were collecting those metrics along the way. So often we start these programs and then we try and figure out what data we need, and we really spent a lot of time upfront recognizing that and identifying what it was going to take to determine the success and show the success of that program. The other piece of the data component was really leveraging data that we had at our fingertips. So Trenner mentioned, there's a lot of data available. So we were heat mapping across the state of Pennsylvania. Where did we have high rates of food insecurity in the populations that we served? We linked that up with EMR data to say, where did we have a high prevalence of uncontrolled type 2 diabetes? We heat mapped that with our community health needs assessment to really pinpoint and focus on an area where we knew that the program would likely demonstrate a lot of impact. We knew we had high rates of food insecurity. We knew we had high prevalence of type 2 diabetes. So we wanted to make sure that we were targeting the right population. And I think that's really important too. So it's identification of the population, and then it's also being able to pinpoint where and when and measure those outcomes and measure their progress. And we did that by incorporating a social determinant screening question in our EMR that all of our patients answered. So the second piece of that is, I think, and why we've been successful in this space, and while we've been successful, are also still learning, is that we've been flexible and adaptable. level. I think you have to remain flexible. This is a very new space. There are things that you're going to encounter when you get into these programs or when you get into the data. And it's really, it can be a lot of work. And there's some challenges with, as Trenner mentioned, even just making sure you have the right business agreements for data sharing. And this data is not data that's historically stored in a health record. And so just working through all those pieces, we're really coming up against some things that just the industry hasn't seen historically. And so, you have to be willing to be flexible and adapt as those things happen. Even within the program itself, our Fresh Food Pharmacy program, which is really using food as medicine to address type 2 diabetes, primarily in the food insecure population. We've learned so much over the years of that program. We adapted pieces every time we stood up another facility. For those who aren't familiar with the program, it is using food as medicine to treat type 2 diabetes by providing enough food for 10 meals a week for the patient and their entire family. It's not pre-made meals. It's actually about a 2,000 square foot facility where people come in and grocery shop, just like they go to the grocery store, and they have lean meats, whole grains, fresh fruits and vegetables, everything that they need. But we connect that very closely with the clinical care and making sure that they have the registered nurse, registered dietitians, all the wraparound services that they need in order to be successful in managing their type 2 diabetes. And what we've proven is that we're able to demonstrate a 2.5 reduction in hemoglobin A1C consistently in that population, which is better in some cases than a lot of medications. And in fact, our only side effects, we joke and say, is lower weight, lower cholesterol, and some other really important factors there too in overall health. And so it was really disruptive in this space. It was really thinking about things very differently in this space, but the success of that was largely driven by the data, by really measuring those outcomes. And we continue to keep that as kind of a guiding principle in our programs. Hopefully, Kim, that answered the question in the chat.
Yeah, I think so, Allison. And I always love hearing about that program. I think it's for lack of a better term, it's so cool. So each of you mentioned data and analytics as something contributing to success and really foundational for these efforts. I'm wondering if you can share with the audience how we can leverage the data that you're collecting and use that along with technology to solve for health disparities and social determinants of health. Trenner, I know you have a really great framework for thinking about this. I'm wondering if you can share that to start us off.
Yeah, Kim, thanks. I think you're referring to the very simple idea that we talk about the what, the so what, and the now what, a lot of times with our customers and with our partners. So when we think about the what, it's the identifying and the characterizing that risk. So understanding, to Allison's point, who has high risk for food insecurity, but also transportation or housing instability and financial strain as part of that. The so what is using the data. So once you create that baseline understanding, that visibility of social risk at the person, every individual person, and then look across maybe up to millions of people literally at a time, integrating that with claims data or clinical data so we can say, what's the so what? Like, how does social risk fundamentally impact and create variation in clinical outcomes, like Allison just talked about with hemoglobin A1Cs, or financial outcomes, utilization patterns, experience churn that Andrew talked about before. The now what, I think, is where we all, maybe across the country, have the biggest leap to make, which is, that's great. What do we do now? So we understand the risk, we understand the impact on our business, right? But what do we actually do? And I think they're really thoughtful programs, again, and Andrew, Allison, and Lucille can talk about them, but understanding how does that impact what I think about maybe care management and the direct connection, social work, care management, care coordination that I have with a patient or a member? Or how does it inform which community-based partners do based on the supply and demand? So using the data to quantify what risk look like for the population that we care for, and for the resources that are there to support people around that. How do you better understand, based on the needs of the people that you care about and care for, what partners do you need to support that? And thirdly, and I would argue maybe most importantly because of the impact they can have, how do you thoughtfully design intervention programs, right? So with intention that we talked about before, using the data to guide both whom you can have the most impact on, and what type of program with what type of partner, whether it's a program like Geisinger is running there independently as part of that, or you're leveraging national companies that come in like Wisdo that works with Andrew and the Humana team that can address loneliness and social connectedness as part of that. But using the data to be the guide of where you can have the greatest impact and allowing organizations to prioritize those efforts, I think is key.
Great, thanks, Trenner. Lucille, why don't we turn it over to you?
Sure, Kim. You know, Trenner, a lot of what you're saying is so true, and it kind of links into what we do also at CVS. If we take all the data and all those indices that we pulled into, we knew, you know, access to healthcare services was one of the 4 pillars that we really wanted to address. And being at CVS, we knew that there were the disadvantaged and minority populations that faced barriers to care, more difficult for them than the general population. So we just recently launched a nationwide virtual healthcare service where we know that these disadvantaged populations often don't even have an ongoing relationship with a PCP or don't have access to one. So we looked at taking all that data and identifying what are some of our pillars that we really want to address: access to healthcare. And then outcome-wise, the now what is trying to build that virtual care capability. And if you think about, to your point, Kim, early on about the COVID testing and requirements, right, and the vaccinations, we looked at and knew that minority communities were disproportionately impacted by the pandemic. And so when we set up our testing facilities, we leveraged that data to find the underserved populations that didn't have access. And we rolled out those vaccinations when we had that limited supply in the communities identified. And so I think that data allowed us to really zone in on those outcomes that we're all looking for, right, is to get that access to healthcare services and increase testing and screening. So I think if I would have to look at it, that data element connected into reaching right people at the right time with the right resources and interventions, and then most importantly, meeting them where they are at in their care.
Thanks, Lucille. And Allison, why don't we turn it over to you next?
Sure, and I think Lucille and Trenner really spoke so pointedly to this. You know, it really is about using data to create that holistic approach to healthcare, right? And being able to have those care teams have all the information that they need, but then also serving up that data in a way that the care teams can use it effectively to manage the patient or the member or whoever that they're working with. Integrating that and embedding that into their workflows as part of their standard practice is a really critical piece of all of this. And we were somewhat naive, frankly. You know, I think in the chat there was a question about whether food is the toughest issue, and quite frankly, it's all tough. For different reasons, right? You know, transportation is tough because it's expensive. As a healthcare system, we went down that path, and we have a transportation pilot in flight right now. While we're showing, you know, pretty good outcomes, there's also, you know, a high cost to providing transportation. And so I think they all individually have their own challenges. I think where we were naive, though, is that when we started this journey 4 years ago, we were tackling them individually. So we built the Fresh Food Pharmacy program to tackle food insecurity. We built a transportation program to pilot transportation. The reality is in many of these situations, the individuals that we're providing the service to, they don't have just one social determinant of health, right? So at the end of the day, our Fresh Food Pharmacy patients have transportation issues. Our transportation folks have food insecurity issues. And so it's so important to get to this kind of longitudinal, holistic approach when we think about social determinants of health. And we really quickly in our Fresh Food Pharmacy had to hire a community health worker just to try and tackle some of those other social determinants. And so having the infrastructure and the tools for those care team members to be able to successfully provide services and support to the patients and the members that we're working with is really, really critical. So it's all the underlying data when you're trying to make the decisions from a programming standpoint, but it's also how important the data is with just the day-to-day care management piece. And I love what Lucille said about, right care at the right time. It's just so important in this work, and something we're also very focused on.
Thanks, Allison. And let me close this out by going to Andrew, who I know, has tackled multiple social determinants of health. And I know I've heard you talk a lot about like the data ecosystem that in which you look at these issues. So Andrew, can you talk a little bit more about that and how you leverage technology to address these issues?
Sure, absolutely. So I kind of think about it in two ways. First, I'll talk about the data, and then I'll talk about technology for solutions. So, a lot's been said already about the importance of data and different types of data. For us, I think about it's been important for us to create a taxonomy around it. And I think about 3 tiers of data that we consider. There's known data, first of all. It's kind of the gold standard. If we have a validated screening instrument on someone, or we have an ICD-10 code or something like that, that's known data. Then we have derived data. So if we don't have that first tier, then we go to derived data. And that's when you start thinking about predictive models or risk indices. So we have predictive models for things like food insecurity, loneliness, and transportation. And we have a consolidated social risk index that we use to kind of understand overall social risk. So that's tier 2. And if we can't get either of those two, then the third tier is inferred data. And that's where we import a lot of external geospatial data sets. So thinking about census data, CDC 500 cities, Robert Wood Johnson Foundation data, a lot of those different kinds of things, consumer data even that we may purchase. So there's 3 tiers in that taxonomy, and then it's about the business rules of how do you approach that? Like what do you do with that type of data? We would approach a patient differently if we have a known screener that they're food insecure, versus if there's a predictive model that says there's some likelihood that they have it, versus a geospatial set that says they live in an area where there's some degree of food insecurity. So we have to think about that in terms of how we outreach and how we approach a person. And then, so once we have that type of information, we do need to reach out, and we do need to leverage technology more and more. And I think the pandemic, among many, many other things, has taught us that we need to leverage technology. When we can't get together face to face, we have to think about, can we go old school and reach out to people via telephone, which we've done for things like a social determinant call team that we've done, where we go and kind of triage against a bunch of different needs. Or, Trenner mentioned Wisdo. We work with Wisdo. It's kind of an app that connects people in a virtual kind of environment to, go through a lot of health and wellness and prevention type activities. Or Uniper is another one where you actually send a device to someone's home where they can access content and things like that. So there's a lot of different ways to approach it. And I appreciate too the comment on, these things are multifactorial. If one social need exists, often many more exist as well. And so we need to start taking a more holistic approach. So whether it's a call team, a person calling and triaging multiple needs, or increasingly we're working with what we call SHARP platforms, or social health access referral platforms. There's some of the, Unite Us and NowPow and Aunt Bertha and some of those organizations that help kind of consolidate a lot of community-based organizations and then triage multiple social needs to connect people to the right community-based resource. And technology is a really key component of assessing for the need and then connecting to the appropriate community-based resource and make sure availability is there and connectivity is there and so forth and so on.
Great. Thanks, Andrew. This has been such a great discussion of what works well, what you all are doing, takeaways for our audience. I imagine as you've launched and strengthened and scaled your programs, you've learned quite a few lessons along the way. Before we move to audience Q&A, can you share with our audience some pitfalls to avoid or things to keep in mind as you're developing, strengthening, or sustaining programs to address social determinants of health? Allison, why don't we start with you this time?
Yeah, so I think I may have already said a couple as far as just kind of making sure that you prepare for, especially from a programming standpoint, that you really prepare that it's often not just one social determinant of health or one unmet need. And so I think taking that holistic approach and planning for that out of the gate is really important. I think the other thing that we recognized is that you have to, in this space, not allow perfection to get in the way of progress. And I think we hear that a lot, just in a lot of other areas, but in particular, this one, I think it's even more relevant. And so I think it's really, really important to make sure that you iterate, and that you recognize that not every program is transferable. Not every program is going to resonate with a community in the same way. I think it's really important to understand what that community looks like, not just from a patient standpoint, but you have to take into consideration a lot of other community factors and how community-based organizations play a role in this work. I think one of the things we learned when we stood up a fresh food pharmacy in Scranton is that we were actually seen as a competitor to other food pantries in that area. That was a very eye-opening experience for us. I don't think I expected that, but because of the funding streams and the way those food pantries are funded and set up, they saw us as coming in and potentially taking their patients away or their clients away, and then that would negatively impact their funding. So just recognizing some of those factors, how the community-based organizations really do play a role in this work. And even though our objective ultimately was actually to try and help them be even more sustainable in the long term, and we need them so much for this work, we didn't recognize the fact, when we came into that community, how that may have been portrayed. So those were some of the lessons we learned along the way. We keep learning, and I think that's probably the biggest lesson. Just don't be afraid to keep learning, because it's definitely a challenging space. It's a new space, but it's good work, and the people who are doing this work are ultimately very mission driven, and so it's nice. The one positive I'll leave on a positive note is where I've really seen great value is in people kind of in this space dropping maybe the competitiveness, especially across the healthcare streams and even the insurance streams, and recognizing that we're really in this together and coming up with a solution that's sustainable is going to benefit everybody. And so I've been refreshed that there's been much more open communication, and that people are willing to share their stories and look for that best in practice type of approach. And so I want to leave on that positive note.
Great. Thanks, Allison. Lucille, how about you? What are some lessons you've learned around pitfalls to avoid?
So Kim, I'll flip it to maybe some best practices from the learnings. I would say the investment in really the data. You heard a lot of the challenges that we all had to face in bringing in all these different indices and data sources. So one is really the investment in the team, a dedicated team to look at the data, because that is like the foundation of how that integrates into the rest of your processes, your capabilities, your programs. And then I would say looking at your internal resources, there's your colleague resource groups, there's these multicultural teams that really want to be part of these projects. So embrace the opportunity to bring in a multicultural set of colleagues and part of I'll call it either the champions or your governance team that helps bring in that component of it into your projects. And then, we learned that with the data, we were properly identifying potentially the right individuals, but back to what Allison said, it was the engagement at the community level that really you have to invest in at the local based organization. So I think those were some of the best practices, and not one size doesn't always fit all in some of these, but that would be what I would have taken away and encourage individuals that are thinking about this to invest in the resources and the ability to sort of execute on this whole end-to-end component with the data and then all the way through to execution.
Thanks, Lucille. And Andrew, I know Orundhati mentioned that you spoke at this conference back in 2016. I'm wondering if you can share some of the lessons that you've picked up along the way to today.
Sure. Yeah, it's been a long time since 2016. I appreciate the comments, first of all, that Allison and Lucille both said. I think what I would add is maybe a couple of things. One, I think increasingly to address social needs, we've worked with community-based organizations, and often that means a referral to a food bank or a community center or something like that. But what that really means sort of in reality is that often we are sort of reducing capacity to address other things. And one thing that we really need to keep in mind is we're gonna refer more people to these community-based resources. We need to make them whole, and we need to ultimately create additional capacity to serve more people over a longer period of time. And that's a challenge in that a lot of CBOs are nonprofits, they're grant funded, they don't have a sort of traditional way to monetize their services. And so we got to figure out how to work with them and make them whole so we can sustain the work. So that's maybe point one. Point two is, I'm a data nerd and I keep talking about data, but I think data is really important. You've got to have really good data and you've got to measure everything, because I think it's the proof points of the impact that will justify bigger investments in this work that create scalability and sustainability for the work, because we all believe in it. We all believe social determinants and addressing them is the right thing to do, but we've got to be able to show the proof points that it actually has an impact on health and health outcomes. And so that's something that, I continually learn, and I, struggle sometimes, but I think we need to get there because we need to scale and sustain the work. And in terms of scaling it, what I found is the most effective way to scale is through integration into other work streams. And so by that, I mean taking a pilot and not necessarily turning it into a standalone program, but integrating into clinical operating models, integrating into value-based care payment innovation programs, integrating into supplemental benefits on Medicare Advantage plans, but integrating it into different work streams as opposed to creating something completely new from scratch, I think is a quicker and more effective way of scaling this work.
Thanks, Andrew. And Trenner, last to you.
Thanks, Kim, and such great comments from everybody. Maybe the first, and it gets a little bit, I think Allison is the one who said it, but there's not just one right answer. So when we think about social risk intelligence and all the potential use cases, don't let perfect be the enemy of good or great. There's so many ways that organizations can use this intelligence, right, to better act and have impact on the people that they care about. I would argue one of the most important things where we've seen success is being able just to pick a starting point, use the data, and not just data, right? Use actionable insights from a strategic standpoint. How do you set up a program, for whom, with which partners as part of that? The idea of doing things with a community, not to a community, but using intention to be able to better understand that for sure. One of the second pieces is making sure, I think, where we've seen some of the greatest opportunity and organizations really succeed is when they maybe look at the people that haven't been enrolled in a program, that have addressable risk, but have not yet been engaged or touched by that program, and using the data and those insights to better proactively reach out to those people that have the most addressable risk and have real impact as part of that. The third piece is, I think, that these programs, and Allison, you talked about it a bunch, like they will evolve, they should evolve. We will learn all the time what's working, how do I continue to tweak it? How do I understand better on an ongoing way? Not when a program is over, but mid-flight, because as Andrew said, you measure everything, that we understand what's happening during the process and we can make tweaks. So if we realize that the people that we were proactively trying to reach out to who have food insecurity, also maybe the ones that aren't showing up have additional transportation risk, we know it's that subset, right? And we can evolve that program mid-flight. If we're measuring it along the way, we can make those decisions collectively to better address that risk in a really thoughtful way. So super excited. The last piece I will add is it's so important when we think about that measurement. It's not just as healthcare entities, right? What matters to us, whether that's cost or utilization or even clinical outcomes. Two additional things to think about. One is the partners that we bring in. So if it's a produce prescription store with a grocery store or a food program, understanding that the metrics that matter to them may not be emergency room utilization or total cost of care. So how do we measure that impact for them? And then for the individuals themselves that are enrolled, yes, it's important for them not to be in the emergency room or not to be admitted to the hospital. But I think about like ProMedica as an example, who's got a financial opportunity training and support center where two of the metrics involve monthly income. So increase in monthly income is a measurement that they look at, as well as changes in credit score. Those matter a lot to those individuals that participate. So it's the participants, it's the partners, and it's the health care providers as part of that as well.
Thanks, Trenner. So I wanted to segue now into some audience Q&A, and there's a question in the chat, and I think the gist of it is, there's some interesting and innovative and different approaches being taken by maybe non-healthcare or maybe rural and tribal area providers. I'm wondering your thoughts or the panel's thoughts on how we might be able to learn from and collaborate with groups who we may not have traditionally engaged with in the healthcare arena, who are addressing social determinants of health or addressing things like food insecurity, access to healthy foods and nutritious foods, or other issues related to health equity. Trenner, maybe back over to you, and then I'll open it up to the group as well.
Yeah, just really quickly, I think I'll echo what a number of people have said so far today. This amazing opportunity that we have to listen and engage our communities that we're involved in, that there's so much really great work that's going on. The value, right, and the opportunity I think we have from a healthcare standpoint is we can be conveners, right? We can pull people together. We may, as Andrew said, we can think about that reimbursement and how we make sure, right, that we're not adding, patients or members, right, to a nonprofit without the ability to address the capacity that they have. So I think our biggest responsibility / opportunity is engaging the communities where work is already going on so that we can, again, do this together.
Yeah, and I'll just add to that, Kim, if that's okay. I know we've talked a lot about food security. I know that question was focused on that. I probably should have been a little bit more specific. In our footprint, one of our clinics actually still has a hitching post, and it's still used today. So we're about as rural as you can get. And another one of our food pantries is in a food desert. And it goes to using that data, right? It's not just the data, the clinical data, but it's also using that data as far as where are the food deserts in some of these areas that we're working with. And it is important. I echo what Trenner said, engaging. That's really when we talk about the community-based organizations, it's not even just physical organizations. It could be organizations of individuals or different areas that have just expertise that we don't have. And we recognize that, in healthcare, we really need those resources and we need that expertise in order for us to be successful. So, it was mentioned earlier, we philosophically made a change probably about 5 or 6 years ago as an organization that we were going to stop doing things to the community and for the community. And really, we were going to engage in a totally different level and partner with our community stakeholders. And I just think that's such an important piece of all of this work. But it was a great question and definitely a good discussion.
Thanks. Well, I think we might have time for one more audience question if anyone has any. Now they're all coming through the chat. So this one came in first, and it's, what do the panelists believe are the biggest sources or pools of untapped data that could enable the flagging of patients with actionable SDOH-related issues? Andrew, this might be, since you're our data nerd, a question that I flip over to you.
Yeah, well, and I'm probably not the only data nerd on this panel. Trenner, I'm looking at you, but we're probably all data nerds to an extent. I mean, I think that it's important to have frameworks for how you think about data. And so one framework is to think about health as holistic health. So there's physical health, mental health, and social health, and putting it in those sort of columns. And then I think more vertically in my mind, I think spatially, I think about that, sort of known data, derived data, and inferred data. So known data is best. If you can ask a person directly, are you food insecure or not? That's ideal. If you don't have that, it's taking all the other data that you have available and doing things to be able to predict what a likelihood of having something. So predictive models and social risk indices and things like that. And absent that, then you look for community data or geospatial data sets or data that you can purchase. So that's everywhere. And I think you just have to know how to use it and know how to mine it. So thinking about census data and Robert Wood Johnson, CDC, and credit card data that you can purchase, you can learn so much about an individual, what they buy, what they do, where they go, what kind of services they access. And putting that in the context of holistic health, I think is often an untapped resource.
Thanks. Trenner, Allison, or Lucille, other comments here?
Lucille?
I was just going to add, sometimes your own organization has untapped data. If you have all this data stored within your healthcare organization, I think Allison mentioned it earlier. It's not maybe coded in a way that you can pull it out easily. So I wouldn't, take a step back into your own data source. What are you already bringing in? You're interacting with individuals on a daily basis through care management programs, one-on-ones, through providers. What can you be doing internally to take that data and put it into a field that is transferable and added to the many hundreds of indices that you're using in your algorithms? So I think that to me was one aha for us internally, is how can we take all this great data that we had and be able to pull it through to build our algorithms with all the other data sources that were out there.
Maybe just to highlight a little bit of that, to double tap on what Lucille said, there's so much data that we never ever will have a problem anymore with getting data. It really is. We actually have, in some respects, too much, right? Because sifting through that, and Lucille, you said it, it's the algorithms and the thoughtful framework, right, that organizations need to be able to turn all of that data, public, aggregate, individual data, into actionable insights. Without that, right, then you're sort of awash with data, but not able to really act on it. One categorical area that I think about that we haven't maybe talked about as much, and maybe it's just sort of near and dear to my heart right now, is we're thinking a lot about digital equity and understanding digital equity as the robust sort of opportunities related to telehealth and teleservices. As we think about rural healthcare and opportunities, understanding what people's access is, right? Whether it's digital, virtual care as part of that, access to even information just to better understand and navigate the healthcare ecosystem is one of those. So it's not really a source, but it's one of the domains as we think about opportunities from a social risk standpoint that we think will be increasingly important.
Yeah,
Thanks so much.
Sorry.
Go ahead, Allison.
No, I was just going to say, just to add one more piece of that's not as specific to the data, but recognizing that when you do have that data, when that becomes available, remembering the human component of it, right? And I think sometimes I struggle with this a little bit. We get so focused on the data, you get rich data, you get excited about what you're going to do with the data. Sometimes, you have to figure out how that actually fits into the workflows of the care teams. What makes sense for them, what can be easily incorporated into their care plans and their practice. But then also, sometimes we have all this data, but we don't have a solution for it. So we struggled with this when we started asking the food insecurity question at Geisinger. We really held off until we knew we could have some type of solution, not just for those who were eligible for the Fresh Food Pharmacy program, but for anybody who answered that they were food insecure. Because the worst thing you can do is ask the question or have the data and not do anything with it. But that's a big task, to be able to have programs and solutions in place to be able to support the great need, because it is a great need. And so that's just one more point that I'd mention in regards to the data.
Thanks, Allison, and thanks everyone for sharing your expertise with us. I hope that folks have taken something away from here that they can apply in their own environments. Let me turn it back over to Arundhati, because I believe we are at the end of our session.
We have a minute left, so I'm actually going to ask a question. Allison, I'll direct it over to you, and then perhaps the other members of the panel can answer as well. Yesterday, we had a panel on home health, and the issue of social determinants and health equity came up over there as well. And one of the panelists had an interesting answer. He was talking about how providers sometimes have programs or clinical trials run by companies where nurses go into the home of people for blood draws and things like that. And that is another way to get insight as to what is the true nature. Is there food at home? What's the situation at home? I'm wondering if this can be scaled. Is this something that you are doing at Geisinger, where you're leveraging folks that actually go into the home?
Yeah, absolutely. We have a program at Geisinger. It's actually called Geisinger at Home, and so it's specifically nurses and actually advanced practitioners who even will go into the homes. But the first point of contact in the home is usually a community health worker. So they go in, they do an assessment of the home, they identify if there's any issues with food insecurity, fall risks, things like that. They're really doing that holistic assessment. And that was a lot of the reason that we decided to get a platform in place. We do have a referral platform. We use Aunt Bertha at Geisinger to be able to provide that linkage to community-based organizations. Because what was happening is they were going into homes and they were realizing that they did not have a lot of options. They were Googling things, or they were, phoning a friend or trying to figure out if there was a church down the street that could help. And so we needed to have a way to really kind of bring that together so that the individuals and the care team members who were going in had a single source that they could search for reliable information. And so when we talk about kind of the digital component of this and how important it is for the care teams, that was a really fundamental part of our at-home program and something we leverage regularly.
Excellent. I think we're officially over time. So thank you so much, all of you. This was a great discussion. This was an important discussion. And for anyone who wants the video, we are recording each of these sessions. And so all attendees will receive links to the recording most likely next week. So thank you again, Trenner, Kim, Allison, Lucille, and Andrew.